Hi, folks. Steve Urban here, founder and CEO at Riderflex. We hope you enjoy today's podcast. And as a reminder, please subscribe to the Riderflex show for updates on new episodes. And by the way, if you haven't already, check out the book we recently launched, The Riderflex Guide, Inspiring and Hiring, available for purchase on Amazon. And now, a quick word from our sponsor.
Try the #1 marketing platform for small business. Everything you need from design to marketing to CRM. Learn more at marketing360.com. Marketing 360. Fuel your brand.
Christine, should I call you Dr. Lum Lung, or should I call you Christine?
Please call me Christine.
Okay. I love the name, by the way. Lum Lung. That's great name.
Fairly unique.
Totally. Do your friends call you doctor, or they call you Christine?
They call me Christine.
How about your family?
They actually call me Christine as well. My dad used to call me Chris long time ago, but lengthened out into the mature name of Christine.
Tell me about your family and where you grew up a little bit. Give me some early history, if you don't mind.
Very early. My dad was in the military, so I was actually born overseas.
Okay.
So I was born in Germany. In fact, had dual citizenship until I was 18.
Oh, cool.
Yeah, and then they give you a choice, and I thought it'd be cool to choose the German citizenship, and my mom's like, no. She's like, you have no idea what kind of problems you'll create. But anyway, I carried a dual citizenship for a couple of years, but grew up in Colorado, really for the most of my life. We spent some time on the East Coast in New Jersey. I come from a family. My parents both worked growing up. My mom was a pediatric ICU nurse, and then went and got her NP, nurse practitioner degree in pulmonary, and worked actually at National Jewish down in Denver.
Okay.
And my dad was an engineer, and he worked he was a communication specialist with US West, Quest, the gamut, I forget what it is right now, CenturyLink. I have 3 sibs. I'm the second. So I have an older brother who's also a physician. He's an ER physician.
Okay.
I have a younger brother who is a college counselor at a prep school out in San Jose. And then a sister who's been the jack of all trades. She's an accountant by training, homeschooled, taught, does a little bit of everything.
Does she happen to be a CPA as well?
Yes.
Is she looking for a career change? I'm trying to fill one of the.
I don't know. I'll ask her.
I don't know if you know, Riderflex, we have the podcast, of course, but our day job is a recruiting and staffing firm. And a good friend of mine, who's also our tax accountant for the company, is in Fort Collins. Where's she live?
In Colorado Springs.
Oh, bummer. Well, never mind. Anyway, I've been trying to fill a tax accountant spot for him. So
Okay.
your parents must be super proud, right? They have to be.
I hope, yes, they are. My parents are incredible. I mean, they're just such a blessing. I tell people, and I know we'll get into Origin a little bit later, but when I told them the idea about Origin, it was, in the middle of a pandemic, healthcare was, just suffering in so many ways. And I approached my parents and said, I think I'm going to leave my company that I started, secure a job, and I'm going to go launch this startup thing. And any good self-respecting parents would have been like, what are you doing? Have you thought about your economic safety? And my parents were like, that is incredible. Absolutely, you should do that. So
Really?
from day one, they've been, and that's how they've been my entire life. They're just such amazing parents and such great support. Never let us believe there wasn't anything that we couldn't do.
That's awesome. They're still married, still healthy, still.
Yeah, they're definitely still married. They're such a great couple. My mom's had some health issues these last couple of years, which have been really, really stressful in the family. And it's been very eye-opening for me as a daughter who's a physician. Definitely gives you that empathy for being on the caregiver side of healthcare and how difficult healthcare is for patients and families.
Totally. Are they in Northern Colorado? Because I think do you live in Fort Collins?
I do. They lived in the Littleton area, and we actually, they just moved down to Phoenix within the last half year, where my brother is. So they're closer to my brother, grandkids, all the sporting events and school activities to keep Papa busy. So,
and warmer in the winter.
And super hot now, having just been down there. 115 smoking degrees. I actually I worked in Arizona for a while. but
Oh,
it's
you did?
been, yeah, it's been a bit. So it's definitely hot,
Yeah, I'm not a fan. In Arizona in the summertime, no, I'm not. No,
but they have great winners. To your point, they have great winners.
totally. I don't know if you know this, but I live off the Johnstown exit just south of Loveland. So
Oh
me
yeah,
and you, we're pretty
we're
close.
neighbors. We're
Yeah.
neighbors. Absolutely.
How about this construction in Northern Colorado the last few years? Crazy, right?
Awesome. Love it. Yeah. Such a fan of it. It makes travel super predictable, like smooth sailing all the time.
Had
Ooh.
some people come in from California to see us, and they get here, and he's like, "Man, your whole state's under construction."
Oh my gosh, doesn't it feel like that's always the way? Yeah. I'll be happy when it's done.
And totally. When we first moved to Johnstown, it had one stoplight, and and there was nothing up there by 34 and I-25 where
Yeah.
Shields on. It was none of that was there.
I know. I've been here 18 years now, and same thing. Like it
Yeah.
has grown exponentially.
Crazy. Okay, so were you always the straight A student, perfect kid? Like, they knew you were going to be a doctor, never did anything wrong. Did Christine ever, is there any like rebel stuff in here you can share with us? I mean, come on.
All right, who's been talking? I will not lie that I was that straight arrow good kid. I won't even tell you a story, but my brother-in-law listens to this. He'll know the story of what happened when I showed up to college as the goody goody. But I didn't always get straight A's. Biochem killed me in college. I hated biochem. So that was my not straight A. But I was definitely more of the straight and narrow girl. I'm not going to lie. And I knew from 6th grade that I wanted to be a doctor.
Really? Wow.
Yeah.
Because your mom influenced you there a bunch, I guess. I'm sure.
Actually, interestingly enough, she told me not to go into healthcare. I mean, my mom had the foresight years ago to know how much healthcare was going to change and how chaotic it was going to be. But like any good daughter, you don't listen to your mom and you just say, you said not go into healthcare? I'll go into healthcare. So, I mean, her being, in the healthcare field and watching, her lead with that servant heart definitely played into the choice.
Okay, very good. So you knew you were going to be a doctor the whole time. You got into Yale after CU, right? I mean, wow. Hey, congratulations. That's a big deal.
So Yale was my executive MBA, so my MBA program that I just did. I entered into that, and that will go into the origin, the origin story of origin. But I did that in 2019. So signed up to do that before we knew what was about to happen. So it was commuting out to Yale every other weekend for what was basically the full gamut of the MBA program, collapsed into a crash weekend and then, a bunch of work. But it was an incredible experience. I met some amazing people. We ended up going online for, once March 2020 hit, we were no longer obviously traveling. And people will tell me like, that probably helps you quite a bit. I would have given anything to still travel out there every other weekend. Just the fellowship and the networking was incredible.
You recommend for the listeners, this is probably good, give them a little tip here. When I first made it to C-level, I ran a couple of companies before starting Riderflex, and had several conversations. People were like, "Hey, you need to go get your executive MBA," and I'm like, I don't have time to breathe. I'm running a $40 million company here. I'm like, I can't even. What are you talking about? But was it worth it? I mean, do you recommend it?
Great question. So I think every individual needs to really decide. To your point, I was the solo founder and CEO of an independent hospital medicine company that I ran up here for 16 years before going to Origin, and didn't have my MBA doing that. Now, one could argue, should I have done that without an MBA? So I don't know that you absolutely needed it. I would say, and it's a debate for physicians quite a bit. If you're looking to sort of move into other things that are not direct patient care, do you need it? I would say for me and for people in healthcare, one of the values I think is expanding your network. Our entire trajectory, apparently for me from 6th grade, was all about healthcare. You go all about sort of this healthcare path. You go into med school, you go into residency, fellowship, and it's all prescripted. And so you're really only meeting healthcare people. So going to Yale was fantastic to meet people outside of healthcare, to learn different perspectives. And then I would say, often as clinicians in healthcare, we're told that we can't fix healthcare because we don't understand. We don't understand how it works. So just go see patients and let the rest of us. And so I knew that I needed that tool in my toolbox
I
to
see.
even open doors for people to believe that I had what it takes to, to innovate and drive the change that we're looking for.
Did you have an entrepreneurial bug or an entrepreneurial spirit? I mean, you were practicing and then you were like, oh, I'm going to start my own thing sooner or later. How did that even happen?
Yeah. So I never intentionally set out, and then, to say that I was going to be an entrepreneur, I would say, the first one was my first company. So I was practicing in Arizona. Right. We were talking about Arizona a little bit for about 4 years with a hospital medicine company that I joined right after I finished residency.
Okay.
And then started this, I call it the voice in the back of my head. There were things that I did not like about how the group was working and other things about the system. And I got that voice saying, well, if I could start my own group, this is what I would do differently. Okay. Started looking to see, what else was out there about coming home to Colorado, was given the opportunity to start a program here in the Fort Collins area.
How? What do you mean? What does that mean? Define that for the listeners, given an opportunity. Yeah.
So honestly, I was trying to decide about coming back to Colorado, was just looking on job boards, and there was a posting, honestly, it was Poudre Valley Hospital at the time, that said, looking to start a hospitalist program. It was as ironic as that. I was coming out and was interviewing in Denver, had 3 interviews set up. And so I called and said, I have half a day left that I can squeeze you guys in. Drove up. They said, we're looking to start a program. You've been running, you've had a program experience for a couple of years. You want to take this and run with it. And so I sort of put my money where my mouth is. I took a massive pay cut. I mean, there's something for your listeners, right? When you're looking at, moving, it may not always be incrementally, from a revenue standpoint, looks like there's gains, but sometimes you sort of have to step to the side in order to keep moving up. So took a significant pay cut to come here and start the group. But the value of being able to run and create the program the way that I wanted to was fantastic. So super proud of the company that I created. I ran that for 16 years. And then that voice came back. And I was having these very difficult conversations with patients where I felt like all I could say was, yeah, I know our healthcare system stinks, doesn't it? And that voice was like, well, why don't you go do something about it then, right? You have the business experience, you have the clinical experience, so go out there and see what to do. So when I went to Yale, honestly, I told my group I was going to leave at the end of the MBA program, but I didn't know yet what it was going to do. I wasn't going there to start Origin. I was going there to make healthcare better, and just said, I'm going to be open to whatever that means, whatever comes my way. And then through a series of events we can talk about a little later, it was very evident that Origin was what that was going to look like.
Well, you were the founder at the hospitalist program, right? You had equity, you owned it. Were you a majority equity holder? How does that even work? For the listeners, a kind of a commoner cap table ownership perspective, can you describe how that even works?
Sure. This is different than the traditional. If someone's listening to this thinking about like sort of the VC startup or how Origin is going to work, we didn't set that up to be an investable. This was, for me, I wanted to create an amazing physician practice that people loved and wanted to work in, that we would grow, and that did all of the things that the providers in there needed it to do, give them a good, stable job, honor the time that they want with their family. So all the physicians were owners. Essentially, you would come in as a junior partner, employed. And then after your first year, the partnership would vote you in. We didn't want any pyramid scheme or anything. We wanted everyone to be very bought in. And I think there were fewer and fewer hospitalist groups that were physician owned throughout the time that we ran, because it's really complicated to run a practice. There's a lot with electronic medical records. There's a lot of regulatory. Our group said having that ownership experience is just going to be better for everyone. It's going to be better for the patient, better for the people that are working here. And so we were an independently owned group when there were fewer and fewer groups. And we really were able to then pull people into that practice who had sort of that ownership, bug themselves.
Wow. Now your role there, were you still seeing patients, or were you just running into business?
I was doing both. I was working clinically full-time and running the practice full-time.
Wow. Okay. Yeah, you were busy. Okay.
Got a little busier when the MBA program started too. And then, COVID, as I tell people, I think the most formidable time that I can ever talk about in my entire career was I was transferring, I was leaving the company at the end of 20, the beginning of 21. So I basically had to take 16 years of my CEO experience and transfer it to the incoming CEO. We were in the middle of a pandemic, and we were a hospitalist group. So our docs were at the front line of this very unknown pandemic. Right. I was having to fight for PPE for them to get them safety, worried about their safety. How do we schedule going to school at that time, and still practicing. So those are the times I look back and think, if I can get through that, I can pretty much get through anything.
What was your social situation? Did you have a family? Would you have relationships? What was going on with that?
Yeah, I'm not married. So that there is there is a lot. I think when I talk to my female founder friends who have a husband and children, I mean, that's a whole nother level. Now, it's nice to have that support crew with you as built-in support crew. Somebody do those dishes in the sink, please. But at the same time, I can sort of drive my schedule and not have to worry about, getting some to school in the morning. So incredible admiration, especially for those female founders out there who are founding companies and running, a household.
Well, I'm thinking about you, and I've been a CEO, so I know the life. It can be a lonely, stressful life. And if you were single the whole time, you're at home. Those nights when you're at home, you're laying in bed, you're nobody to talk to.
My family is my family still doesn't screen my calls for whatever crazy reason. They haven't put a block on my phone calls. So my sibs and my parents will always take a call. And then I think just, find yourself an incredible co-founder.
Did you have a co-founder at the first one?
Not with the first one.
Okay.
The hospital was already looking to recruit. And so there were two new residents that came out, but they were fresh out of residency. So I was the one that had the business experience and basically did the structuring of the business of the practice itself.
Okay. For the listeners, and I probably should know this based on my trying to study you last night and this morning, but when you were seeing patients, was it general care? Was it specialized in certain areas? Do you mind sharing that with the listeners?
So a hospitalist is somebody who doesn't have an office. They actually see people in the hospital. So your primary care doc may see you in the office and say, Steve, you need to be admitted for pneumonia. You would be admitted to me in the hospital. I would take care of you for your pneumonia, and that it would transition your care back to your regular outpatient doc. So we're sort of the inpatient arm of people's primary care. The hospitalist, there are different arms of it, but traditionally we are adult medicine. And we basically, the easiest way is we don't take care of people that are requiring surgery. We can consult on them or having babies, but heart failure, pneumonia, infections, dehydration, anything on your medical surgical unit will be covered by a hospitalist. And really, those are the patients that we're actually looking to take care of as well with Origin. So that's where that translates.
Yeah, very good. Before we get into Origin, a couple of questions. Yeah, I've always kind of wondered how that works. I appreciate you sharing that with the group. I would guess most of the listeners don't actually know how that works. Yeah, I've always kind of wondered. So yeah, my family doctor says go over to Greeley and check in, and then all of a sudden I got two or three other doctors coming in, and I didn't really.
Hospital medicine, yeah, I think hospital medicine. When I started the group here 18 years ago, it was still very new. So I had to go around and tell people, like, this is why you would want to admit to a separate group. And in the beginning, there were people that said, hey, we'll never admit to, a group we don't know. And now hospital medicine is so ubiquitous that through US, almost every hospital has it, because the outpatient world has gotten so busy and stressful. They're seeing panels of 20, 30 patients a day. Yeah. How do you have time to stop you in the middle of the day, go admit one of your patients to the hospital, get back and pick your clinic up again, take phone calls. Yeah. And, we're in the hospital, so we can see people. If you get admitted at 3 a.m., you're going to get the same exact care and treatment as if you got admitted at 3 p.m. because there's somebody there to see you right away. And so that primary care space really evolved into outpatient and inpatient being their own specialties.
Did you like once you started the business aspect and running a company administratively from the CEO chair, if you had to force rank it, did you like the business aspect more than seeing the patients?
I will always be a physician at the core. I mean, that's why I went into healthcare and it grounds me so much when I have a patient encounter. So I will always treat patients clinically. I like the business aspect of it because I liked being able to say, it is possible to create a program with high integrity and run this the way that we need to answer patients. I mean, that being able to actually have an idea and be able to develop it and bring people on board was fantastic. Now, as a CEO, there are CEO jobs and roles that I would love to not have done as the CEO. So it's not all great, right? The buck stops there with you, and you definitely have to be able to handle the bad and the good. But I liked both of them. But I'll always be a physician at my core.
You said something right there. You said use the word grounded. Yeah. Anytime I visit a hospital for whatever reason, right? Man, I always come out of there just kind of humbled, grateful. I don't know, all those other words where I'm just like, okay, I'm breathing. I'm pretty healthy. I'm starting my Jeep. I'm driving away. Like, oh man, there's a lot of people in that building not doing that right now, And so, yes, very, yeah, I get it. I totally get it. Okay. So what were you, so congratulations, on what you built, right? The hospitalist. I mean, congratulations on building that. You were there for 17 years. What was it you were seeing? What was bothering you to say, I want to do something else? Kind of walk us through that a little bit.
Yeah, there would be different scenarios where, it could be, so I told the story of our first patient we had with Origin, because she actually reflects. So, a patient who came in struggling to breathe, she was diagnosed with a heart failure exacerbation. They said, you need to be admitted for treatment, and she said, I can't. She has an adult son at home. His mental health treatment means she has to give him his medicines. And so she said, if I end up in the hospital, he'll get worse. The cops will be called. I can't do this. And so here's someone that was sacrificing her own health. She wanted to get better, but we weren't giving her options to do that. We would have people in the hospital who, separated from their loved ones, would have a lot of anxiety and depression. They'd be in the hospital, other patients would come in, and because unfortunately people don't get up and move around as much in the hospital, now all of a sudden they need a nursing home. And when they came in fully ambulatory, we've had patients who left against medical advice because their pet was home and there was no one to take care of them. I just kept seeing that there was all of these situations where we weren't providing patients with options. I describe it as like we had created this binary system in healthcare that you're either inpatient or outpatient, then there's nothing in between. And really felt like there was this opportunity, especially because the literature and people doing this overseas for decades, there is this new wedge of healthcare. It doesn't need to be inpatient or outpatient. We can create this new space where you're getting inpatient level care in the comfort of your home and do it much better. And so that was, for me, transformative to say, this has to be something where we can really meet our patients' needs, decide what they need, and then build the support system around them instead of, basically anchoring them to a facility and then building the needs around them. It's not and then we know, like, access is such an issue for people. Rural communities don't have hospitals that they can go to and are driving hours. People of different socioeconomic backgrounds have been, unfortunately, not treated well in the healthcare system before. And so they'll put off getting healthcare until it's really too late. Now they're in the intensive care unit. So we really felt that there was a space to create options that really met the needs of patients better and opened up that opportunity for them to get the care when and where they need it the most.
Yeah, I would just assume, and I'm not an expert on it, but I would assume almost not every, like 80% of the patients you would see in the hospital, they're always saying, Christine, when can I go home? 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 When can I go? Yes. Constantly.
Yes. And because technology has really advanced. So my co-founder, she worked in the cardiothoracic ICU at UCLA. And when we were taking care of some of our first patients, she was used to these super intense on ECMO, multiple drips. We're seeing these patients, and she was asking me, she's like, would these patients be in the hospital? And I said, yes. Unfortunately, a lot of these patients in the medical unit are getting once a day antibiotics, once a day labs. And then for 23 hours, they're sitting in a super expensive bed, isolated from their family, at risk of infections. The hospital, unfortunately, we need hospitals, but it's not a benign place for people. Infections happen, adverse events happen. And so, that's what was so intriguing about this model, is this model had been rigorously studied. And by every metric that we cared about in healthcare, all of those quality metrics and safety metrics were better when patients got care in their home. Mental health scores were better. And then the key for me was the cost of care was 30 to 40% lower. So it's like, we have the 4-leaf clover of healthcare, like literally in front of us.
Wow. Yeah. Why not do it? I would, I want to get into the costs and things and get into some specifics, but I was also thinking, Is it true? Is there a stat on this? Do men in general not go to the doctor and not go to the hospital? They wait longer than they should. Are they worse about that than women, or do you have a stat on that? I'm just curious.
I think the stat is a lot of it is for the preventative care, not necessarily the acute episodes of care. It's still about 50-50 in there, but unless you ask wives that are going to be listening to this, in which the case they'll say, absolutely, Steve.
I mean, I hear that. I've heard that. I mean, there was a guy, there was a case right here in Johnstown where a guy, he was an older man down the street, and his foot got infected and toe got infected or something. I can't remember. And he wouldn't go. He wouldn't go to the hospital.
Yep.
Waited too late, killed him.
Yeah. Right. And so this is someone who says, hey, I don't want to go to the hospital, but I know I need treatment. If someone will come to my home, yeah, I'll take treatment. I want to get better.
You could have saved him. Yeah, guarantee it. He's a perfect example of that. Guarantee it. Yep. Perfect example. Okay. How does it, the financial, well, all right, before we get into that, maybe we just do an Origin healthcare overview. Let's do a quick elevator pitch for everybody that's hasn't heard of it or doesn't know. Go ahead and give us the overview first, and then I'll hit you with some more specifics.
Yeah. So some of it's come up in our conversation, but really Origin Healthcare. So we're a tech-enabled healthcare company. Our goal basically is to move care out of the high-cost facilities into the home, where we know that patients will get better quality, we can improve access to care, and then significantly lower cost of care. And we do this by partnering with different organizations and helping them either by bringing the clinical team, the platform, and the technology to basically allow the patients to receive high acuity advanced care at home, similar to what you would get in a hospital setting.
You said organizations. Do you mean hospitals? Do you mean insurance groups? Do you both?
So our customers, right, our end users are the patients. Those are the ones that we really want this service supply. But who's going to pay for this, right? Because patients don't typically, outside of their co-pays, pay for this. So a couple of our partnerships, we partnered early with self-funded employers. So we have already 14 self-funded employers in the region who basically have created a payment mechanism for us to do this care. And let me step back. One of the things that we were talking about is this showing such great quality results, such great savings. Why wasn't this, right? Your listeners ask, why haven't we had this before? Why does Australia, Italy, Spain, why have they been doing it for decades? Well, if you look at what's happening there, right, they have more universal health care where there's better alignment between, we need to figure out a way to improve quality and lower cost. Our payment insurance system here in the US is problematic. So this fee for service, there was never a way to capture hospital level payments outside of a hospital. But we've worked with some of us, our self-funded employers who have their own benefit plan. They can allow us to receive payments that would be on par with what you would receive at a hospital, but we significantly discount that. So now the employers getting significant savings and their employees getting better outcomes. So we're creating payment opportunities for this model that had not previously existed. And then COVID opened up those opportunities because Medicare now has also put in place a waiver that is allowing payment through the end of 2024 in this sort of pilot period of time.
Okay, I'm going to ask some questions that we want to apologize for ahead of time because I'm ignorant to some of the language. But
no, it's okay.
I'm going to assume some of my listeners are too. When you say self-funded employers are able to do this, can you give me an example of some that are like self-funded and some that aren't, and what's the difference? Can you explain that a little further?
Yeah, so a lot of the US gets their healthcare from their employer. Okay. So their employer could have a traditional plan where they're basically, for 100 employees, they pay premiums for those 100 employees to a traditional insurance company. Okay. And then there's, the employees have their copay, their deductible, everything else. Right.
Yeah.
What we're finding though is that, especially as healthcare costs rise in the double digits every year, and those employers are facing a 20%, premium increase year after year, especially not seeing the value, is that these plans have moved to what are called self-funded plans. So they basically said, we're not going to pay premiums. We're going to set aside a percentage of, make a little bank account essentially of healthcare funds that we're going to pay. So Steve, when you go to the doctor, we're going to pay out of our bank account. We're not going to be paying a routine. This way it allows them to control their costs. They're actually paying only when healthcare is being used essentially. About 60% of the employer groups actually have a self-funded plan. That way you can actually create benefit plans. You can decide, I want a wellness benefit and I'm going to add a gym membership on, and this is how I'm going to pay for it. I'm going to add on Origin so that my employees can get hospital level care at home, because a traditional plan wouldn't allow that. Some places say, hey, if you need a back surgery, we've worked with a center of excellence. It's not even in Colorado, it's in another state, but their cost and their outcomes are better. And so we're going to pay. So they basically get to create their own plan to really drive value and lower those costs and create benefits to their employees that are really meaningful and that they'll use.
Why wouldn't every company do that?
Why wouldn't you? So I think some people are fearful, and there's something called a stop loss, right? Because you wouldn't want to say, hey, I'm going to get bankrupt essentially if, I have a bad year and all my employees use healthcare. There's a stop loss. So you'll hit a ceiling where you say, after this, insurance will kick in so you won't bankrupt your company. So it's new and unknown. I mean, it's not new. I think if you haven't heard of it before, it feels scary, but a lot of the brokers will say, most companies should be moving to self-funded plans.
And Kaiser and United Healthcare and those guys, they hate this, right? Because they lose business.
So like a group like United, they work in the self-funded plans, acting as what's called a third-party administrator. So you still need someone to process the claim. Now, whether having a traditional insurer be your TPA or have an independent TPA and deciding sort of whose interests are being best served, I think I'll let that sort of sit as a debate for everybody.
Yes.
But yes, it's like I said, I think there's more and more companies that are going to move to it, because companies can't be competitive anymore when you're spending so much money on healthcare benefits that people don't end up using and then don't get you the value. If this is a way that you can align yourself with groups where you're going to help improve your cost and increase value to your employees.
Interesting. My question around Kaiser and United and things like that is, as I'm listening to you, I'm trying to figure out who your enemies are, right? Or who's not going to like what you're doing because it's
Everybody
a loss for them. I don't know. I know enemies is not the right word. I'm kind of half joking, but I mean, if you're cutting into somebody out there, I'm sure is like, whoa, wait a minute. This is hurting our business, I think, right?
So obviously self-funded employers love it, because we don't charge per member per month. So this is like, you are going to automatically save. And when you're talking about hospitalizations, I mean, that's like a $6,000 to $10,000 savings for a single hospitalization. There's very few benefit levers that an employer can move that, even if just one of their employees uses it, will yield that type of benefit.
Wow.
The other partners we look at is we're looking for working with the clinicians, the primary care groups, especially as more of them are moving towards value-based payments, where they're taking on the entire episode risk, where an insurance plan will say to this practice, we're going to give you the cost of what we think it's supposed to be for you to manage your 100 patients on your panel. If you manage them more efficiently, you get to keep that extra money. If it costs you more, then you can't come ask us for more money, right? And so these groups are really looking to say, where can we help improve quality for our patient population so that we can manage that cost efficiently. And since hospitalizations are the most expensive episode of care, we can come in and help partner with those. Insurance companies, you can think again, hey, let's lower premium costs, help drive patients to our plans. Hospitals is the one that people will pull up most often, as they must hate you. But again, hospitals have been under such stress lately. They're already full, they're at capacity. There's actually a consulting group that works for the National Hospital at Home Users Group that I'm heard of, that has, and McKinsey just came out and built this amazing return on investment, because I think, Steve, the stat that was most surprising to me is that it costs $2 to $5 million to add a single one bed to a hospital.
Really?
So if you can actually not build a tower and say that hospitalizations are basically a level of care, not a location of care, then we cannot spend that CapEx on building new big shiny towers and put people in an environment where they're getting better care and where they want to be in the first place. So it's sort of shifting the mentality.
When the hospital executive calls you and like, Christine, you're cutting into my business. So you're like, hey, look, here's the McKinsey report. Just look at this.
Yeah. Here's the ROI. And then, some of the value-based metrics that they get dinged on nowadays for readmission, poor patient experience scores, hospital-acquired infections, all of those metrics are better when you get your care at home. So if you can help a system avoid the penalties that they get incurred, so 50% of the hospitals get readmission penalties each year. So if you can think about how can we partner with the system to help improve your metrics in a way, I think, people will say that ultimately where hospitals are going in the future is that it'll be an emergency department, an ICU, and surgery, right? Everything else we know can be done safely. we're seeing that more and more care is moving to the home. People, because of COVID, are more comfortable getting care in the home. Technology with the ability to monitor vital signs, do telehealth visits. The hospital is going to look very different in the future. And so this is that early movement towards sort of the redesign of healthcare.
When are they gonna, I don't want to go down a rabbit hole here, but just really quick, when are they going to have some sort of machine to where I can I can do a blood draw or a urine sample, stick it into a little machine and not have to go to a building and wait for the results? When is that already available?
They do a lot. There's more and more being done in the home. So there's phlebotomy in the home where you can actually do your own lab draws in the home. There's, these total body scanners in the future, right? The Jetsons, we're going to walk into our home and, the body scanner is going to tell us what's going on in our body and what we need to do.
And it's going to give me an injection automatically. I don't have to go to the, yes, please. I want one of those right now. I need I need that machine now, today.
1 or 2 more years.
That will be so awesome. I mean, I love, do you know Dr. Kennisburg, Johnstown, Greeley Hospital, Kennisburg family doctor?
As a hospitalist, I would have taken care of some of his patients.
Yeah. I mean, I love Kennisburg. He's great. I've been going to him for years. We joke around and stuff, but so often I go to his office, I'm like, Dr. K, I'm like, really? I had to come in here for this? Like you were in here for 3 minutes. Like we could have just had a chat on the phone.
Well, and think about the fact that you mentioned earlier, you have a Jeep that you can get into, think about those patients that, are older and can't drive and don't have family members that can take time off work to take them to the doctor's office. So, let's figure out how we actually make it easier for them to get the care that they need.
I would think, okay, so you are not only saving money for the companies, the self-funding companies, you're saving people in various ways. You're making it more comfortable for the patients. You're increasing the number of times somebody probably actually would be seen or get something done because they don't have to go to the hospital. And if they can get it done at home, they're more likely to have it looked at or whatever. All those are great things. I'm trying to figure out why we wouldn't just steamroll forward. Like what's the holdup?
Yeah. Somebody said to me, this is so logical. And that's why we continue to plug away at this. This is just so logical.
Yeah.
This healthcare system in the US, while great in so many ways, still is not set up in a way that really truly puts the patient at the center. We're in a sort of a fee-for-service world where money dictates and then volume then dictates, where the money flows. And there are a lot of players that are entrenched in healthcare that have a lot of power to make decisions.
Like the pharmaceutical companies.
Pharmaceuticals, hospitals, insurers, they all have a lot of market power in different ways. And the dynamics of healthcare, I've learned a lot, having even run a company for 16 years prior to getting in here and feeling like I understood some of the backside of healthcare. I've discovered a lot more in these last couple of years.
Have you had any, who's more powerful, pharmaceutical companies or insurance companies?
So I'm not going to, they're probably a tie. I would also say hospitals carry a lot of power as well, too. And there's more and more consolidation, with hospital systems joining and, whether or not consolidation and, moving away from, we're strong proponents of the independent, not corporate owned healthcare entities, practitioners. So a big supporter of them and think that there's a lot of value in maintaining some independent groups out there.
Have you had any dark cars with shaded windows outside your home?
Where is this going to play? Yeah. So, when you're drawing attention to things, there are people who, if you're, again, we want to partner with hospitals, we want to partner with insurers, but, everybody's sort of got to get on this bus that we know that healthcare needs to change. It needs to move. Our clinicians are burning out. We saw the capacity challenges that our hospitals are facing. People aren't going in. More and more rural communities are without hospitals now. I tell people I'll go to these medical conferences, and every year we see the healthcare spending curve that logarithmically is going off the screen. And the speaker says, we can't keep spending almost 20% of our GDP. And by the way, seeing our quality down here, this can't keep going. And yet Another year later, you're in a different conference room with a different speaker showing the same. I mean, at some point, we have to commit as a nation to say, we can't keep spending at this rate and not see the value. And for me, this hospital at home movement, it's better value and lower cost of care. This is exactly what our healthcare system needs. We just need to realign people's incentives to help make something like this, like you said, a no-brainer.
Yeah, a couple of more questions here. And then I want to ask about some bigger picture questions on universal healthcare and things like that. Does this include Dr. K coming to my house or just other stuff that has to be done?
Yep. So we send a nurse and a nurse practitioner to the home, and then the physician does a telemedicine visit. We have remote monitoring where we have a watch that tracks heart rate, O2 oxygen. It tracks your steps, your sleep, and it's paired with a tablet where you push one button and you can telehealth 24 hours a day with an origin physician.
Okay.
We do IVs in the home. You can get radiology in the home. You can get labs in the home.
How do you do x-rays in the home? How do you do that?
We partner with a couple mobile x-ray companies. They can actually do everything except for CAT scan and MRI, although I have seen a portable MRI scanner that's in development. So who knows, at some point, everything.
Well, that's going to be that MRI machine. That's going to be the same machine I stand in that I get scanned and the injection comes in. It's all going to be the same.
A built-in Swiss Army knife.
I want one of those right now. How do you, so you make money? What's the business model for you?
So as a physician, when I go see a patient in the hospital, I can bill, because I'm credentialed with insurances, I bill what's called a CPT code. So I can say, hey, this was a level 3 visit for Mr. Jones in the hospital, and the insurance company pays me a rate that is $100 or $200 for that visit.
Okay.
The hospital, however, gets something called a DRG. So the hospital from the insurance plan says, okay, Mr. Jones is admitted for COPD. We've negotiated with the hospital, and we're going to pay the hospital $10,000. That's going to take care of Mr. Jones' room, board, nursing, supplies, everything. So what we're doing is we're saying, hey, we know that we can provide care. The studies will show 30 to 40% lower cost of care. We think we can do it even more efficiently than that. So self-funded plan, you would pay the hospital $10,000 for Mr. Jones. Now you can pay us $5,000, let's say. So you're going to save $5,000 to your bottom line. We now have $5,000 that we get to deploy our staff, the equipment, everything. We don't have overhead costs like the hospital do. You tend to run more efficiently. And so we're basically taking hospital level payments that far exceed what clinicians themselves could capture or bill in a clinical model. And that's what drives this revenue model. So our partners are gaining with savings.
Okay. And the people you're sending to the house, the experts that you're sending to the house, the doctors, the nurses, do they also have other jobs at the hospital and they're doing this for you on the side, or are they just with you? How does that work?
So our goal is to always employ the clinicians when we're bringing the clinicians, because we're a startup. Some of our clinicians still work part-time in other jobs, some in the hospital and some other places, but they're employed by us. So we're not doing, we don't do outsourcing work, essentially. They are Origin employees for the time that they work with Origin.
Okay. And are you US? Are you Colorado? Where are you in the scope so far?
Yep. So we launched in 2021. And so we've been working in the Northern Colorado market. So for listeners that aren't from Colorado, it's sort of the upper half of the state. We've served 37 different zip codes and over 1,200 patients so far. So we really learned these last couple of years, what does the care team, what does the pathway, the operations need to look like? We've been building some of those relationships with the partners that we've talked about. And so we're at this point where we're looking to scale both within Colorado and outside of Colorado.
And have you taken on funding? What's your cash situation? And are you in a current raise? What's the scoop there?
So we bootstrapped and have been revenue generating up until now. So we had not taken on any outside funding. We opened up a friends and family round about a month or so ago. So we have some friends and family. We won a grant from, there was a competition here in Colorado for healthcare groups. And so we won a grant. And then we launched our first, what would be a seed round, since we've been revenue generating, even though we haven't raised. We've launched a $2 million seed round within the last month.
Okay. I want to talk to you about that offline. You're still working on that seed round, right? You said launch, so it's not. Okay.
Correct.
All right. Very good. Now I can't, as an individual, individuals like me listening to this that live in Northern Colorado, they're going to hear this and go, okay, I want this. but they can't really, as an individual, how do I get that? How do I get the service?
So great. So the model of what they call hospital at home. So, hey, this would be something, Steve, that you would actually be physically in the hospital for. We typically want a clinician to have said, Steve, you need hospital level care. That way you're not sitting at home with a heart attack waiting for us to show up, or, so we want to make sure safety wise, hey, this is something we can take care of at home. And really for the people that pay the fee of this, they want to make sure we're not just calling it hospital at home to capture that higher rate when really it's just an urgent care level visit. That being said, we do urgent care. So if you have a cough, a fever, or a cold at home, you could call Origin and we could send a team to come to see you and do your labs, radiology. So the non-hospital
I'm sorry to cut you off right there, but my Kaiser insurance won't pay for that.
So Kaiser, we actually are not in network with Kaiser, but all the others. So if you have traditional Cigna, United, Anthem, because as a clinician, I'm contracted with them, I can come in and do that single episode visit, capturing that clinician fee. It's the hospital at home that's different, a different payment mechanism. And those are the things we're unlocking right now to allow those payments to come at the hospital at home. But we are doing those visits at home. We're doing visits when people are coming out of the hospital facility. It's a really high risk period of time. And one of the things I just want to make sure I do say is that, the care that we're giving high level expert care. There's this massive benefit for your clinical team to see you at home. We're finding out so much that we don't know about patients by being in their home environment, seeing how they're storing their medications, what their food looks like, what their social environment is like. We're able to really interact with caregivers and say, what is it that you're not getting, that you're struggling with? There's so much benefit. So we're getting you better in that acute episode, but man, we're doing so much that's going to keep you healthy in the long run. I have worked in the hospital my entire career until now. It has been eye-opening to me how much we don't know about patients.
Yeah, that's a great point. I wanted to clarify something though, really quick. So if I live in Northern Colorado, as long as I don't have Kaiser, and I want to be seen at home and I don't want to have to go to the doctor, I can go to originhc.com, log on or call
us. Yep.
And as long as you're partnered with my insurance, you'll send somebody here.
Exactly. As long as, again, if you have a broken leg, like we don't have ortho on our team. So there may be still diagnoses that we can't take care of. And right now, just again, we do 18 and above. We don't yet have the ability to do pediatrics. We're looking to bring that on, but right now we don't do peds.
Okay. One more question. I know what my wife's going to say. She's going to say, yeah, but I like my doctor. I don't want to see a stranger. Well, how do you respond to that?
So it's the same question we used to get when the hospital medicine, like if you got admitted to the hospital, you would be seeing me instead of Dr. Kindesberg. And so we want to partner with your primary care. We don't want to take the place of your primary care. This is, again, for people that are acutely ill. A lot of times it may be hard for them to get to a doctor's appointment. Family may have to get daycare for their kids if they're going to, go sit for half a day in the urgent care. So we're there to help for those people who are struggling, getting the care and the time that they need it. But we absolutely don't want to take the place of a primary care team. We want to partner with them, be their eyes and ears in the home, help them when they don't have the ability to bring a patient in.
Okay, very good. Are there others doing this? Do you have competition? You don't have to mention on the competition, but are you up against a bunch of other people? Are you first entry into this whole thing or what?
So there are a couple other big groups that are, really well funded in the last couple of years who were, there's some that are in the home space that are looking to develop the hospital at home component. We came in with the hospital at home being our first, and there are others that they partner just with hospital systems. So they don't have the option to bring the clinical team in like we are. So we're saying, hey, we want to be able to partner with self-funded employers, with value-based provider groups. So we have that wider market adoption because we haven't used the hospital as just our anchor point.
Okay. Do you have a personal whiteboarded plan? Like I'm going to grow this until X and sell it, or right now you're just having fun building it?
We're definitely having fun building it. We believe in the model that we've created. We have amazing quality outcomes and we have a 97% net promoter score. So we feel like this model is so needed. The space and the market opportunity is massively open at this time. And so our big goal now is finding those people who are ready for this and that want to partner, and we want to be off and running with it.
Okay. Right now, technically, you're still in control, right, of the company on the cap table.
Yes.
Okay. Very good. That's probably a very good thing. You know, as soon as somebody hands you $100 million, it's going to be different, but you know,
Right.
you don't
It's
have to
one
worry
of the
about
reasons,
it.
it's one of the reasons we bootstrapped initially, is to try to really have the time that we needed to create the program the way we wanted to.
Yeah, very good. Okay. Excellent. OriginHC.com.
Yep.
I want to ask you a couple of big picture, other topic questions before we run out of time. Can I?
Okay. Absolutely.
Because you're a doctor, and I just want your insight on this. And you may not want to answer, so you can just let me know if you want me to cut this out.
Okay.
As a doctor, I'm just curious. Like I said, if you don't want to answer this, I totally understand. What is your short 2-minute answer on how COVID was managed in the US? Did we do good? Did we do bad? What would you have done differently? Do you have any? I mean, I'm just curious. I know you were in it. You were in it, right? When it was going down. Just curious. What were your thoughts like when you reflect back as a doctor? What do you think?
Yeah. You know, we were at a period of time that, you know, they'll be writing about us in the history books, and you know, most of us never want to be in a period of time in the history books. So none of us would have experienced a pandemic before. So all that being said, I know that everybody tried the best that they could do. It was super chaotic. I think, you know, this goes back to just basic business. You know, how do you run a business and how do you keep people? There was communication breakdowns along the way. People stuck with sort of their, you know, this is how we always do it, and weren't able to think outside the box in a way that created, you know, safety opportunities. You know, again, having to fight for PPE and not be able to bring our own in. That was one of the, you know, statements that we got, is we couldn't bring our own PPE in, but yet we weren't being given it. You know, things like that. I think if a lot of ways that, you know, we should have fallen back from a leadership standpoint. That being said, the people on the front line, amazing. And that means frontline in the hospital, frontline in the grocery store. I mean, all the people doing the work. I think there's a lot from a leadership perspective that people need to take back at the government level, at the business level, that all need to reflect on. I think the individuals that were out there doing the best they can, again, you know, have families at home, kids all homeschooled, still trying to work. I mean, so many great stories during that period of time, but I think it is definitely a place where people need to pause at a leadership level and think how they could do better.
Okay. Next big picture question, last one, then we'll wrap up. If you had the power and you could make the decision, would you make the US universal healthcare like some other countries?
So no, not specifically universal. I do think we need to move like more towards that. This is where I'm tethered at. I'm a capitalist by nature. I think there's competition. There's something to be said about competition and sort of making everybody step their game up. We're the only thing in town. We're the only utilities, and I've lost power 5 times in the last year in my home, and you have no option. So there's the business side of me that says, I think a little competition is always good. From the actual healthcare delivery side, and when you look at, again, this model of care being successfully used in countries that have universal healthcare, where they have had to close that gap and say, we need to figure this out quicker because we can't continue to spend our own money at this. And if you look at this from an equity lens, we are not doing well from a health equity lens. And the way we have our healthcare system structured and everybody passing the buck or looking for a 1-year ROI to their shareholders, we will not see the needle move in equity the way we do. So I lean more towards the universal healthcare system, but I would love to see at least maybe 2 players in the space to drive a little competition so that people don't get complacent.
Okay, very good. This is the answer I hear most of the time because I interview a lot of people from overseas. Commonly, I will hear something like this. They'll say, hey, look, for normal day-to-day stuff, small things, regular doctor visits, you know, things like that, universal healthcare, great. Yeah, no problem. If something major happens, I want to come to the US.
Yeah, it's true, right? That is the issue. Even people that I know in Canada, so they come down to the US, you know, to get their emergency care or something else. So what would happen if we didn't have that safety valve for everybody? So as I said, I think we need to move away from what we have today, more towards value, more towards the long, you know, looking at the long game for patients and equity. but I don't think a single payer system would give us
Okay.
the outcomes we wanted.
Christine, I admire what you're doing. You're up against some big players and some big spaces and changing big things. I love it. I mean, I admire what you're
Thanks.
doing. It takes a lot of guts and courage to do that. It takes a lot of energy to be a CEO, a startup CEO. And now you're getting into your cash raise, which is almost like a full-time job.
Yeah, thank you very much. Like, I could not do this on my own. Again, my family is amazing. My co-founder, Jory, the Origin team, like, this is not me on my own. I'm blessed to be surrounded by people who make me want to be a better person and give me the support I need to do that.
Thank you, Christine, for sharing your story. I really
Thanks, Steve.
appreciate it.
Thanks. It was great to meet you.